Hello, everyone. Welcome for another POCUS VMR. Wait, did I admit it? Yeah. Everybody, sorry, I was checking if I have a technical problem to admit it, everyone. Welcome to another POCUS VMR. Today we have Dr. Scott Biggerstaff. He's an internist, a pediatrician, and a director of point of care ultrasound for internal medicine residents in University of Minnesota. We are super happy to have him. Like he participated last year and presented really nice cases on Halloween, and we invited him to be back. So thank you so much, Scott, for being with us. Do you want to say hello?
Yeah, well, it's great to be back. I should have written out clinical problem solvers because I think CPS also is Child Protective Services. So this is not that. This is a POCUS case. But yeah, I can just jump into it if it's cool.
Yeah. Do you want to tell? I don't know. Probably last time I asked you what you like to do outside of medicine. Mm,
Oh yeah. I have a dog and I like to spend time with my dog, walking and running and biking around town. I like to read a lot, do a lot of reading and writing, and yeah, and I love sports, Premier League. I love Liverpool. They've kind of hit the skids the last few weeks, which has been hard to watch. And then Kansas City sports, just been really awesome the last few years on the football side of things. And the Royals, it looks like are finally not embarrassing this year. So yeah, that's what I love.
awesome. A little bit of everything. If you want to start with the case.
Sure. Yeah, before we dive in, I shared these slides last time too, and this is just kind of a good primer. I think point of care ultrasound is limited, right? So we're obtaining limited views. It's not replacing consultative or formal imaging. So it's, a POCUS exam is not a formal ultrasound that's done by a sonographer, interpreted by a radiologist. It's focused. So you have a question, you have a hypothesis, and the POCUS, just like physical exam, is meant to answer that question. And uh, the the exam should be relevant. We're performing it at the bedside, and it's by the managing provider. So you are actively clinically correlating that. I don't see that phrase actually that often anymore in radiology reads, but that was kind of the rub is the radiologist is not there talking to the patient. They don't have a lot of clinical context. They have whatever you typed in the order and what they gleaned from the chart. But you, as the physician who are seeing and talking to this person, um, have a lot more context, and therefore your exam is going to be really valuable in that context. And then this was published a few years back in Journal of Hospital Medicine. It was an editorial, but I like this image a lot. And we go from kind of a skill acquisition, basic knowledge standpoint up to an image interpretation. And then the sort of holy grail is clinical integration. How do I integrate what I'm seeing into my care of this patient and into my clinical reasoning? So this is what we're aiming for. And this is kind of where we start down here. All right. So without further ado, we have a very excited intern who is going to be seeing this patient. But first, we have some information from the emergency department. Do you guys see the this thing? Okay, maybe I'll make that small. All right. So 22-year-old female on the autism spectrum. So she uh, was verbal, but had kind of like limited ability to communicate things, um, and no other pertinent medical history. Develops fever 1 week prior to presentation and has had fever daily since. Uh, Review systems positive for a rash on the front of the chest a few days prior that resolved. And the patient had had a presentation to an urgent care 4 days prior with a rapid strep and flu swab that were negative. Vitals at presentation, blood pressure 115/70, pulse was 134, temp 38.8, and respers 22, SpO2 99% on room air. Exam, patient was non-toxic appearing with a tender neck. The heart rate and rhythm were regular without murmur, normal respers and workup breathing, and cap refill was 2 seconds. All right, so I will kind of open it back up to you guys, and I can go back and show you whatever you need. But what are your initial impressions?
Mangyu, do you want to start?
Oh, sure. Yeah. I feel very grateful for the opportunity to co-discuss at the POCUS VMR. So when I first hear about fever and rash, I jump to the framework of the I made kind of mnemonic that includes infection, especially like the acute course, making me thinking about infection, whether it's viral or later. Then I also thought about bacteria with the throat involvement, perhaps. But then the transient rash also made me more thinking about viral at the initial story. And then I think less likely cancer and autoimmune, I'll just put it aside given the short course at this time. And then drugs, I think, is another consideration. I'll ask more about the drug medication history. And so those are my initial thoughts. I'll ask about exposure, like tick bites or what exposure or season this patient is. And then when I hear about the heart rate and the fever, along with the fever, I first wonder if there's any concern for sepsis, but then it sounds like the cap refill is not that, it's pretty normal. So making me thinking, oh, maybe she's not. However, I think we have to rule out that concern. So I think evaluating something POCUS might be helpful here is to see if the patient is hypovolemic, because if that's the case, if IVC is super narrow, or if the patient responds to fluid, if we don't have the POCUS, then I think those could point towards more hypovolemia. And then the tender neck. Actually, do I have a discussant today? Deborah, will I be co-discussing with you?
Yes, we'll discuss with you.
Yeah, maybe I'll leave that for you, like the tender neck. How do you incorporate that with other findings and additional thoughts you have with other clues?
Scott, can you share again the HPI so we can look, please?
Okay, then should I jump in? I was mesmerized by Dr. Mayhew's approach. Again, thank you, Deb, for the invitation again. Well, now after Dr. Mayhew gave us this bucket, something that I look at whenever I see rash, the first thing that I do is think, is it localized or is it generalized, this rash? Where is it distributed? Do we have mucosal involvement? We know now that it's the severity, there is a certain severity because this patient is tachycardic and he also had fever. So we have this Venn diagram, rash and fever. But before I jump into the conversions of this Venn diagram, I will also think about what is the morphology of this rash. Do we have erythema? Do we have maculopapular lesions? Do we have blisters? There is Nikolsky sign, positive or negative. Is it crusted? Is there any like discoloration, purplish, blackish areas? We know that there are some manifestations that in dermatology that if we see it very obvious discoloration, very toxic, look like a rash, it should like ring a bell of like we should start working ASAP, Now, when we look at this fever with rash, with this onset of 1 week, of course, I'm going to prioritize the bucket of infections until now. So for my next step, I would definitely look for exposures, for allergies, for if this patient, I know he's 22, but he might work somewhere. Maybe he works at a plant nursery or something. Speaking about plants, maybe he has cats or dogs or any other pets, turtles, whatever. Uh, I know I'm trying not to anchor people here. CPS family knows that I really like ID, so I tend to like prioritize that bucket. But in this case, I think it's worth it. What do you think, Dr. Mingy? I don't know if like we should jump for more information.
Yeah, I'm curious if you have any specific differentials or ideas about the throat pain, which seems to have some interesting differentials here as well.
Yeah, like right now, asymptomatic infections, and I'm not prioritizing bacteria so far, but we do also know, if anybody in the chat can correct me, there might be a different sensitivity in the throat swab, but if it's negative, I think we can still put in a second place bacterial infection. I'm not sure. That's a knowledge gap for me.
Yeah, I'm just thinking I would maybe just add I remember we had some cases of the Lemire syndrome, so I'll just keep that in the back of my mind, given the severity of that condition, and maybe imaging, but also like AMK's comment about the potential of thyroiditis, because if the patient is tachycardic but not hypotensive or not septic, then I think thyroid hyperthyroidism is also on the differential, like a subacute thyroiditis.
Yeah, sounds like a good list. You guys are thinking, I think, sort of along the right lines. And so we'll flash forward and I'll give you a little bit more information. Here are the labs from the emergency department. I won't read through everything. Most of it was normal, but there were a few exceptions. So the CRP was mildly elevated to 42, and same with the ESR. And the white count was elevated to just about 20. And then repeated that flu, COVID, RSV swab, and that was negative. And then they also did a little bit of imaging in the emergency department. So XR neck, they did a 2-view neck x-ray, no abnormal prevertebral soft tissue swelling to suggest abscess, and a chest x-ray with findings to suggest viral illness, no focal pneumonia. And just to review, the patient had no respiratory symptoms, no cough, no increased workup breathing, no findings on lung exam. So I'll pause again and let you guys, with that new information, maybe reprioritize your list or determine kind of what's floating to the top for you.
Yeah. Yes. Would you like me to go, or would you like to?
Oh, yeah, please take the mic, Dr. Mingy.
Yeah, I think what I gathered, what jumps out to me was the white leukocytosis pretty significant, even though the pro count is not that high. And then the unimpressive X-ray. I don't know about the viral potential, and maybe there's some bilateral vein infiltrates or something like that. But I think with the white count we have, and the elevated inflammatory markers going along with the white count suggesting the inflammation, whether it's infection or endocrine. But yeah, so I'm still thinking we have to rule out any sepsis or bacterial etiology, along with the other workup for throat pain or pharyngitis, like the mono stuff, mono differentials, including HIV, EBV, CMV, those kind of things. But then we might need additional imaging to, especially if the neck pain, I would clarify more on my exam how localized it is. Maybe imaging like a POCUS will be helpful here if otherwise we would need a CAT scan to look at the. We may need a CAT scan depending on what we find. Yeah, what do you think, Yaz?
I'm right there with you. Another bucket that now is coming up in my differential after seeing this, I think it was a CRP. It's just slightly elevated if I'm wrong. I think this is not really a very intense elevation, but I would also take into consideration this is a 22-year-old male, right? If I'm not wrong, I would also think, could this be a systemic issue? Could this be something autoimmune? There are very, like, in a differential in the lower, my lower places, I would definitely take, I don't know, dermatomyosite. I'm still wondering if we could put autoimmune in this presentation, because he has fever, he has rash, but oh wait, I'm reading at the white blood cell. I'm so sorry, I hadn't looked at that one. It's 19.9. So I'm prioritizing infection, but I also am thinking, well, not only infection can elevate white blood cells. What if this is like an inflammation and there was a trigger? You know, that this patient already had some issues before, and there's a trigger event, and that's where we're having this presentation now. Because you're right, we have this viral panel, but I would definitely ask for an extended one if it's possible, to see if there is any other issue in this patient. So in summary, my 3 buckets will be infectious, autoimmune, or maybe a drug. Drugs can also present with rash and fever. I'm not so sure about the white blood cell, but I will keep it in the back of my mind. Okay, Dr. Scott, do you have more information?
Oh, Dr. Scott, I think you're muted.
Thanks. I had to get at least one of those in. It's a 22-year-old female on the autism spectrum, no prior past medical history. Just to review that part. And yeah, I've got a little bit more info for you. So we're the hospital medicine team. This patient's been seen in the emergency department, and now the H&P is up. So here's from the admitting resident. Patient had sore throat, according to caretaker, treated for strep 5 months prior, had complete resolution. They've been eating and drinking normally. No travel, no animal exposure, no sick contacts. So those are all great things to think of from an infectious disease perspective. Up to date on immunizations, no prior surgeries, not on any medications. They have been alternating ibuprofen and Tylenol for the fevers, but aside from that, had not been on anything chronically. And on the neck exam, it was supple with a small left-sided anterior cervical lymph node. So that they were saying there was some lymphadenopathy and a little bit of tenderness when they went to palpate the neck. The admitting team ordered some labs. So you mentioned EBV, CMV, that came back negative. And I'm sort of detached from the space-time continuum here because some of these things didn't come back till a little bit later, but I'm giving you this information sort of up front. EBV, CMV negative, and then blood cultures didn't grow anything. They did a urinalysis that was normal, and they did give you your extended respiratory viral panel that was negative. And they additionally ordered an echocardiogram, which was normal. And so we're frustrated and excited because we're still sort of uncertain what's going on. And with that new information, anything sort of reprioritized for you, or what would be some next steps for you? So again, we've got eating and drinking normally, strep 5 months ago that was treated. No kind of weird ID exposures, no surgeries or meds. And on exam, we found some left-sided cervical lymphadenopathy with tenderness.
Yeah, yes, I'm happy to go, or
Okay,
would
maybe
like
I can tackle this,
Yeah,
and
perfect.
because I would definitely like to know afterwards what do you think if I did it right. Well, for me, I still have this 3 buckets of systemic infection, of autoimmune disorder, and lymphoproliferative disorder. Why? Because I'm thinking we still don't have very specific symptoms. We only have rash and fever. So we also had lymphadenopathy, and we have this slightly elevated inflammatory markers. Please correct me, like alphos was 142.
I think it was about 130, but yeah, it was like right around there. Mhm.
Okay, so I'm in middle-aged women, I would definitely think about maybe autoimmune disorder on the back, also like uh, just for the lymphadenopathy, rash, and fever, and elevated inflammatory markers. I will have this bucket of systemic lupus disease, very obscure but still on the table, adult onset still disease, and why lymphoproliferative disorder? Because we also have these three things of lymphadenopathy, fever, and rash, with this elevated white blood cell, like highly elevated white blood cells, and this slightly elevated CRP. Maybe we can still think about lymphoma. Please put in the chat, like elevated phosphatase may indicate any like involvement there. Like I would definitely like to see if there's something going on with her liver. I would, those are my initial thoughts, like those three buckets still. But I definitely would like to look at the rash. What do you think, Dr. Magni?
Yeah, I agree. We still have limited information, but when I see the cervical lymphadenopathy and anterior cervical lymphadenopathy, I immediately jump to my like localized lymphadenopathy schema where I think for anterior lymphadenopathy, you think about head and neck, and of course we want to make sure there's no other lymphadenopathy in our body. But like given the acute course and the symptoms kind of centralized around the neck, I was more thinking about more likely it being localized. And then for that, we think about local infections as the most common cause, followed by, like infections mono. And then there's like a rare, like Kikuchi is much less common. So I think of those, I'm still more thinking around the, infections involving the head and neck. And I think we've talked about potential of Lemire syndrome if we visualize the vein in some way with imaging or checking. I don't think we get any signal for thyroid issues here, but I think our exam could be limited. So I think imaging around that just to try to explain depending on how the tachycardia goes, I think some simple labs could also help clarify that. So those are where my mind's now. Yeah.
Cool. Well, we'll kind of motor on. We'll give you guys a little bit more info. I think you're doing a great job of talking through it. We hear there's some localized anterior cervical lymphadenopathy and get excited because that means we're gonna probably grab a probe and take a look at it. And then we tone it down a little bit before we walk in the room so we don't look like a psychopath. And then I'm just gonna this is just a demo of kind of my standard approach on a neck ultrasound. So I'll just play this and kind of talk you through it. I'm going to start usually below the Adam's apple on a male or just kind of low neck on anybody else, and then over the trachea and then transition laterally where I can see the thyroid and the SCM. I scan the thyroid top to bottom, and then I'm going to follow that neurovascular bundle with the carotid and the IJ up to the angle of the mandible, kind of following along the anterior part of the SCM. And then you can see the ECA, ICA split. And I'll play this one more time for you. Again, we start over the trachea here, just kind of low neck. And then I'm going to move laterally. I can see the thyroid and the IJ there, and then the carotid. The SCM is anterior. I'm just going to kind of fan up and down through the thyroid, and then also follow those great vessels there. I know that lymphadenopathy probably is going to show up somewhere anterior to that neurovascular bundle. So that's kind of where I've got my focus. So we go to the patient, and they are not loving the exam. So there's a lot of movement. What I was thinking was maybe this is a suppurative lymphadenitis, and there's a purulent lymph node that I'm going to detect. So this was, I think, maybe the lymph node that the admitting provider felt. And kind of see right there, and then got another look at it. And then as I moved down the neck a little bit and more centrally, saw this, and then the patient really did not enjoy having that area scanned. So I know the image quality is not great, but do you guys pick up on anything?
Yeah, what do you think, Yaz?
For me, it looks, maybe I'm wrong, but honestly, I have never seen a like POCUS. But this looks like it has lobulated structures inside. This doesn't look, I would have thought like something cystic, something, it has good borders, it has well demarcated borders. But I'm not seeing any, it doesn't have a cystic appearance, it's not hypoechoic, it doesn't look like it's filled with water. On the contrary, it looks like lobulated, yeah, like there are compartments inside, like a spider web. What do you think, Dr. Mengyu? I'm really wondering if I'm doing a good interpretation here.
Yeah, I'm along the same line with you. I think I don't do neck ultrasound routinely other than checking the vessels for procedures or so I've never seen this before, but I agree with you. It does look like a mass that has some central lobulations or necrosis. I don't know. Is it thyroid? But I think we have to examine, make sure see if that's the case, or is it like a separate mass lesion or something? But I don't see a vascular structure being like, I don't see like what I was concerned initially was a Lemierre's, like a thrombus in the vein, but it looks more like a discrete mass lesion.
Yeah, I think you guys are thinking through it well. This was confusing for me too. So just to orient us a little bit, the probe marker is up here. This is pointing by convention to the patient's right. And we're on the left side of the neck. So if this is pointing to the patient's right, then the trachea is going to be over here. And you can see a little bit of that kind of air artifact from the trachea right there. So this is just sort of like anterolateral to the trachea. And then you see a little bit of like some vasculature sort of poke in right here. But it's not clearly visible. So yeah, this is like right in the area where the thyroid would be. And then you've got like a little bit of the SCM sort of poking into view up here. So it was confusing. I saw that lymph node and I thought, man, maybe that's the culprit. And then sort of moved down and this was obviously the spot that was more tender and that was sort of bizarre on imaging. So what's your next step after you see this at the bedside?
For me, I think that now that I see this, I don't see, again, correct me if I'm wrong, I try to see like the borders, if it's a well-delineated mass, I don't see any emphysematous appearance, like air on the like upper like areas. So I'm thinking maybe I would definitely ask for a thyroid panel, for inflammatory antibody panel, and yeah, those will be my two. And according to to how big is this mass, as the chat had mentioned, Khashayar, maybe a fine needle aspiration. But yeah, I'm wondering, Dr. Mengyu, like, if I was your intern, did I do it right?
Yeah, I was thinking since Dr. Scott mentioned it's in the area of thyroid, so maybe we should first assess for the thyroid. So I was thinking, like if it's subacute thyroiditis, which can come in with kind of class. This patient's picture kind of fits that because like I'm reviewing the illness script for that. So so the course is usually like preceded by viral infection 2 to 4 weeks ago. Usually mumps were Coxsackie and then develop a transient hyperthyroidism. And then the exam can have a firm heart or painful thyroid, and labs can have high ESR-CRP, and of course we can check the thyroid hormone to see if she's in the hyperthyroid phase, which could explain the tachycardia. And then for imaging, the feature is usually like a transient amorphous or nodular hypoechoic areas, which seems to fit as well, but I don't know enough about thyroid ultrasound. So Yeah, and the differential for that includes like a acute suppurative thyroiditis. I wonder if that's a consideration, like a bacterial infection or a thyroid abscess. But so I think checking thyroid hormone might be my next step, and see if we can see the whole thyroid here.
Yeah, not a bad idea. We did not do that. But our next step was to look at the entire thyroid, and so to order like a formal study. Strange enough for me, where I think it would be helpful to have backup from a radiologist and to get a more protocolized exam. So there's that spot there. Don't know exactly what that is, but think that's probably responsible for the patient's presentation. So we want to characterize it better. And here's the much better ultrasound. And we're looking on the right side. The right side was the normal side. So just to orient you a little bit, you've got trachea here, thyroid. This is the isthmus of the thyroid, and then your great vessels. So your pulsatile, round, thick-walled carotid, and then the internal jugular vein over here. And then if we go over to the left side, we re-image that spot, and now we see it a little bit clearer. And definitely a big, weird looking circular thing with some septations and some heterogeneous imaging findings. So like different echogenicity within that. So yeah, to me, it looks like an abscess at this point. And that sort of begs the question, how does somebody get a thyroid abscess? And then this was just another look at it, I think. Yeah. So it's not small either, so we got 1 centimeter here on the side and then 3 centimeters here. So it's maybe a little bit over 2 centimeters in that dimension. And our read tells us that it was a complex collection involving the left lobe of the thyroid, measuring 3 centimeters, likely an abscess resulting from a fistula from the piriform sinus associated with the 3rd or 4th branchial arch anomaly. So I will pause just after this. Oh. Guess we're going to see the CT too. I will rewind to this. We at this point we're pretty sure that ear, nose, and throat needed to be involved, and so we did talk to them. They recommended a CT to sort of better define the anatomy. Do you guys remember where the piriform sinus is? Little anatomy quiz here.
I have to Google it. Going back to my first year medical school, like developmental biology class.
Yeah, I also misspelled it here. So it's Pyrifom. The piriformis is that muscle that connects the sacrum and then the femoral, that lateral trochanter on the femur. So this is the piriform sinus, Pyriform, and that's near the epiglottis. So it connects to the airway. So what they're saying is there's likely a fistula from that sinus, so from the airway, connecting to a 3rd or 4th branchial arch anomaly. I don't know if any of you are in the midst of studying for step 1, you surely have encountered that. But they're saying that there's this fistulous tract that probably is how this abscess was created. So we talked with ENT and they recommended a CT to better delineate the anatomy. And I've got my mouse pointing there to that abscess. And what we see on the CT is a complex lesion involving the left thyroid gland with peripheral enhancement, thick septations, likely an abscess to the left lobe of the thyroid, probably an infected 4th branchial cleft cyst. So they were kind of going back and forth between 3rd and 4th. But yeah, tell me everything you remember about branchial cleft cysts.
Yeah, I think I have a question. Is this person had hoarseness or started to have like voice issues? Because if I remember well, my step one and like this piriform sinus, like the way that it runs, it's contiguous to the recurrent laryngeal nerve. So I'm wondering if this patient had also hoarseness in any moment of this presentation.
No hoarseness. You know, they were had sort of limited verbal capacity, but were able to talk some, and their caretaker said no voice changes.
Okay.
And they had still been eating and drinking normally, and one thing I didn't include in the initial presentation is one of the things they told us to tip us off that it was probably a neck issue was that the patient was, instead of turning their head, was turning their entire upper body to turn and look at things.
That makes sense a lot. Like normally when as I see it, when there is a neck mass, a good way to do a differential is to see if it moves with swallowing, if there is pain or if it's painless or tender when you palpate it. And if it was just a cyst, it should have been there maybe movable with swallowing and just there existing until it got infected, and then that's when it started like really hurting. Now I'm wondering like what kind of bacteria could have gone there. I'm guessing something from oral flora, maybe strep, maybe as she had a previous infection, maybe something from that went to this little like cyst to the fistula and created an abscess. That's maybe my hypothesis. What do you think, Dr. Menu?
Yeah, my mind kind of now it's going back to my, earlier medical school. I don't think I remember too much, but I see someone, Kashari posted some information in the chat. I just remember it's like a break developmental third and fourth, I think, has something to do with, it's connected to the thyroid. I forgot which one, but could cause there's like a sinus or tract or something connecting the pharynx to the thyroid, and sounds like that's the case with the patient. I'm curious to learn more about this condition.
Yeah, for sure. So next steps, we talked to the ENT a little bit more about this, and they decided to take the patient to the OR. So they did an aspiration, but they also did direct laryngoscopy, and they were able to press on that spot where the abscess was and express 10 cc's of pus into the airway from there, like into the piriform sinus, which was pretty gross to hear. But they ended up isolating strep constellatus, which is a common commensal organism in the airway and also in the GI tract. So probably came from the patient's mouth or airway and just filtered down that tract, and maybe they got like a viral infection. And then that tract maybe swelled and closed shut, so it wasn't communicating anymore with the airway, and then probably that's what produced that localized infection. But pretty remarkable that that abscess was that big, and the patient didn't really have any other significant systemic symptoms. That they were pretty much just having that neck pain and fever. So the ENT follow-up, they called it a left type 3 branchial cleft anomaly, and they wanted to go to the OR for excision of the cyst with possible left hemithyroidectomy. So with these, when they become infected, the providers don't like to do INDs because they don't want to open the thyroid capsule. And so what they recommended we do was treat with antibiotics for sort of an extended course to help the inflammation cool off. And then they would take the patient in probably an outpatient setting to the OR for that hemithyroidectomy. And then they would also cauterize that tract so it couldn't happen again. So branchial cleft cysts, they're 1/3 of congenital neck masses. They tend to parallel the course of an illness during an upper respiratory tract infection, meaning as the patient starts to get sicker, the mass can swell and get bigger. And then as the patient, improves or convalesces, then the mass tends to go back down. So that could tip you off that they have one of these cysts. And let's say a patient presents, probably more commonly a pediatric patient would present with lateral neck swelling associated with a cold or something. Most of the time, that's probably just a lymph node, but there's situations where it could, if it's the same spot every time, that might prompt me to do imaging, like an ultrasound in the outpatient setting to make sure they don't have one of these cysts. A third cleft cyst presents as an abscess, neck mass, or thyroiditis. And so you guys did a great job of calling that out really early. And generally that's because there's that tract to the piriform sinus. So there's the piriform sinus either side of the larynx here, and sort of like that's the area where it was emptying. And you got the epiglottis up here and your vocal cords there. So our differential for that, lateral neck mass is going to include some of these things. And initial imaging choices, ultrasound, oftentimes they have to perform a CT to better delineate the anatomy and see where that tract is, and for surgical planning. And then the treatment generally is going to be surgical excision and then cautery of that tract. And again, we wanted to avoid I&D. I don't know if that's in all cases, but from what I found and what the ENT told me, that's generally what they try to do. If the patient's unstable, and they don't feel great about doing the surgical excision right then I could see a situation where they might do an I&D and leave a drain in. And that was it. So I will I'll let you guys kind of I guess do final teaching points and stuff. And then if you'd like to give feedback or subscribe to my newsletter, then you can scan the QR codes there.
Thank you, Dr. Biggerstaff. Honestly, I really like an infectious case. I am wondering if this patient was put like on a long-term treatment of like antibiotics, 2 to 3 weeks or even more, and also trying to find out like if the trigger event was actually like this strep throat issue of like 5 weeks before. So it's very interesting to see like how just a relatively common malformation, for lack of a better word right now, can be really complicated by this bacteria. Thank you.
Yeah, thank you so much for this case. I learned so much because I haven't seen such a case in the adult world. Although I'm reading, just point of reading, saying that they're common in pediatric neck mass, but usually present in late childhood or early adulthood when previously unrecognized cysts become infected, which is kind of a case in the situation in our case. So, such an amazing case and teaching. Thank you so much, Scott.
Yeah, I think some stuff that's interesting too is sometimes when something like this has been laying dormant for a long time and then something happens and it gets diagnosed, is the family thinks back to, oh yeah, like they always did this thing and now it makes so much more sense. So in this case, this patient was like constantly clearing their throat, and after surgical excision and cautery, that I guess those symptoms had resolved. So it was I'm not really sure how that's contributed to it, but it's kind of fascinating what like nuggets of history end up being consequential a little bit later on once the diagnosis is made. But yeah, cool. Thanks so much for giving me the opportunity to share. Any other questions, I'm happy to answer or field offline.
Amazing. Thank you so much. It was a really quite an interesting case. I think everybody was surprised with the diagnosis. Besh, do you want to share your favorite teaching points about the case?
Sure. Thank you guys, Mingyu and Yaz. That was a very nice discussion. Thoroughly enjoyed it. And Dr. Biggerstaff, thank you for such an interesting case. And, you did a very good job at very briefly and very simply explaining the focus technique to us. So thank you for putting your video in there as well. It was a nice visual. So I'll just quickly go over some of the teaching points today. In this case, we had a 22-year-old female with a history of, with the past medical history of a treated strep throat, which resolved completely. And then she presented in the ER with a 1-week history of fever and rash. And then when the POCUS ultrasound was done, it revealed a complex lesion in the left thyroid gland. And later on, she was diagnosed to have a type 3 congenital branchial cleft cyst. Right. So teaching points here, first of all, you have to keep in mind that POCUS, 3 things that Dr. Biggerstaff highlighted initially is to keep in mind that POCUS is limited. It is focused, and it does not, you always need a backup detailed radiologist, in imaging along with their interpretation of the results. So do not fully rely on the POCUS. And then Yaz did a great job of talking about the rash and its distribution. You want to talk about, look at the morphology. You want to see whether there was mucosal involvement, whether the Nikolsky sign was positive, whether there's any discoloration. So initially, just kind of with a very broad differential, you want to do a very thorough physical exam and take a detailed history to kind of narrow down, and then go towards finding the root cause and also managing the patient at the same time. The next few important points for me were okay, so branchial cleft cysts, first of all, these are one of the most common congenital anomalies in the neck, and they're usually found in the lateral neck. There are 3 types. I believe in this patient had type 3, which is a little lower in the neck, anterior to the sternocleidomastoid muscle. It often presents in late childhood or early adulthood. So around 40% of cases, I was just reading about it on Up to Date, and it says that around 40% of cases usually present after the age 20. So that was a very interesting finding, that it was just right on the upper borderline of that age group. Other than that, imaging for you to image it, you want an ultrasound, which was done in this patient, and then a CT is preferred for identifying the lesion because of its cystic nature. And another thing to keep in mind is that these cysts can very often get infected. And because of the recurrence of these infections, it gets hard to kind of surgically resect these masses because they can create fistulas. And so you want to manage the infection first with antibiotics, and then you can move on towards surgical excision. Lastly, the role of POCUS in neck pathologies, it is a useful initial assessment tool, and follow-up is always needed. It has its own limitations, but in this case, it kind of showed us that there was something, it kind of helped us also localize the focus, and then you can move on and kind of go towards further diagnostics. That is it, guys. Thank you so much for listening. Have a good day.
Thank you so much, Ambesh. Thank you, Wale, for keeping the scribing. Thank you, Scott, for this amazing case, and I hope to see you all tomorrow. Bye-bye.